All right, we will get ready for our next talk. It is my privilege and honor to introduce our keynote speaker, Dr. Cindy Chang. She is a UCSF Professor Emeritus and current Chief Medical Officer of the National Women's Soccer League. She is a specialist in primary care sports medicine with 3 decades of experience caring for athletes of all ages and levels. She was the head team physician at the University of California, Berkeley, Go Bears, for all 27 intercollegiate sports, including football, for 13 years. She also served as Chief Medical Officer for Team USA during the 2008 Beijing Paralympics and the 2012 London Olympics. She assisted in setting up the medical clinics and providing care in the WNBA COVID bubble in July of 2020. She earned her medical degree from the Ohio State University College of Medicine, and then completed residency in family medicine at the UCLA Medical Center, followed by a fellowship in sports medicine at the Ohio State University.
I told you exactly what's
I know, you told me, but there's more. There's so much more.
He asked me what my bio should be. I gave it to him. He's not reading my bio.
Not at all. You get all the flowers.
No, they're falling asleep.
They're not
Let's
falling
just go.
asleep. So most importantly, for the past decade, she has been a personal friend and a mentor to me in the sports medicine field, which I am greatly appreciated for, and she is our keynote speaker of the day.
Thank you.
Right.
Can we do it? Lauren, thank you very much. Lauren, can I use this? Do they both work? Because, I could break out in song any minute now with this little...
Want to take this off?
Yeah, just because I don't...
Yeah, you're good.
Oh, lovely. All right, so this is my topic today, managing complex issues in youth athletes. And when I first was given this topic, I was like, really, Tom? And then I started thinking about it, and I think we all have these types of complex issues. Sometimes we don't think about how we categorize it as such. But can you guys hear me? Yeah. Like this? Perfect. All right, these are my disclosures. The views presented are my own and not reflective of any of these organizations with whom I work or consult. So these are objectives today. Complex issues that can present in sports medicine settings with our youth athletes. We're going to discuss how medical clearance and return to play decisions in youth athletes can be challenging on so many multiple levels, and describe how interdisciplinary healthcare teams like us here can work together to achieve successful outcomes. Oh, went the wrong way, sorry. So starting my toolbox, so just a little bit about my journey. This is me. I am my first year of medical school at the Ohio State University, and I have a wrap on my knee because I had injured my knee the previous day. Now, this was big time, all Ohio medical school basketball tournament. 7 medical schools. We needed to win the trophy. This is one of those things where you still feel like you're an athlete, even though whatever, like, what does this mean? But every time I shot my jump shot and I landed, my knee would shift. But I had no idea what that was because I was a first year medical student and I ended up tearing my ACL. But I didn't know that at the time. And what happened was I was told by the head team physician at Ohio State at the time, an orthopedic surgeon, and again, this is 1985, that I was a girl. He said that. I was in medical school and I wouldn't need my ACL because I was going to just be a doctor. So he did say, you can run, you can bike, but you should probably stop playing basketball, stop playing volleyball, all the sports I love to play. And of course, did I listen to him? No. I was actually a coper, but I didn't know I was a coper. We didn't even have that term back then. But I had enough quad development, glute development that I never shifted. I never felt myself shift when I kept playing sports. And it wasn't until I went into the splits on the dance floor after a particularly joyful night after exams that I then suffered a bucket-handle tear of my medial meniscus. And then I needed to have that resected. That was 66% of my medial meniscus, because they didn't repair them back then, and now I will have a knee replacement surgery soon. But because of this, I decided to pursue a sports medicine fellowship. So as a family physician, I thought to myself, I really need to get better at my musculoskeletal skills, because in family medicine, you learn everything, how to deliver a baby, NICU, all the way to geriatric medicine. but I didn't really learn the nuts and bolts of doing a good knee exam. I wanted to understand the surgical and non-surgical options available to patients with musculoskeletal concerns, because I wasn't given that, and learn the best medical treatment and rehab to get my patients back to sport. And I really was just going to go back home to, I was at UCLA at the time, back home to Ohio and take care of my high school and be the team physician. So this was my early toolbox. And this is me in the fall of 1991, in case you didn't recognize me. And then in 1991, again, Warren Howe is a wonderful man up in Washington, and he wrote the first article about team physician. And he started defining these early definitions of being a team physician and being in the sports field. And I highlighted, rarely provides significant financial remuneration for all those of us who do this, we understand. But what are rewards? Personal satisfaction, check. Opportunity for unique interpersonal relationships, absolutely. Ability to make a meaningful community contribution, absolutely. This is why we do sports medicine, right? And my toolbox got bigger and heavier. The consensus statement, first ever, was written in 2000 with this expert panel. Several of these individuals are the founding members of AMSSM, the American Medical Society for Sports Medicine. But this was the first statement that established a true definition for being a team physician, qualifications, guidelines, etc. Toolbox getting heavier. And in 2013, an update. I was involved in this consensus statement update. There's my name there. And we started adding other definitions, leadership role, ethical issues, medical, legal issues. And you can see this ethical moral compass, which is really important. And all of us have these personal values that guide us in terms of why we do what we do. And, I went through this exercise in a course that I had taken. And these are my 5 core values. For those of you who know me well, they ask us to define it. So my 5 core values are integrity, kindness, not all the time, but I try to be, personal responsibility, fairness. For those of you who know me, I'm so into fairness, and we should all have dictation. Damn it. And family. So those are my core values. But this was really important, and ethical issues came into it. And here's our toolbox, really, really big now, right? And I just participated in the 2024 update in Phoenix just last month. And so that'll be coming up soon. And we continue to make that document longer. But these are some of the challenges, right? Ethical challenges. I think one of the big thing is conflict of interest. We should really be making sure that our patients know if we have any conflict of interest, if we're using a new device or a new type of rehab equipment, is it really been approved? Is it something new that we got a sample of and we're going to demo it? And we need to let our patients know whether or not, does E-stim do what we think it does, right? You don't have to get into all the weeds about it, but, and then leadership skills. And I think the leadership skills are especially valuable because there's going to be times where we need to guide our team to making not the best decision. Yes, the best decision for the athlete and what our patient, our overriding principle should be providing care focused on what is best for the patient and only for the patient. And this is going to permeate through my talk. But essentially, I got so many people that would say, "Oh God, you're the head team doctor for Cal. What an awesome job." And I would say, yeah, it is great in so many ways. I get to work with student athletes. We have 2 student athletes. I have to just call you out because you're sitting right in the front row because I told you to. But we have 2 student athletes from Cal that are here. They play on the women's soccer team, and they're on the track and field team or athletics team. And if you talk to them at lunchtime, they're going to talk a lot about some of these issues that are coming up and some of the challenges that have approached them as student athletes. But essentially, sometimes the team physician or the athletic trainer or the physical therapist, we have to make a hard decision. And so it's not really all roses. What's the phrase? Something in roses? No one's going to know what I'm talking about. But essentially, it's really wine and roses. It's sometimes not wine and roses. sunshine and rainbows, whatever you guys want to say, butterflies and whatever. But you've got to make that hard decision, and it's not a popular decision. But to be an effective leader, leaders shouldn't be, right? If everyone loves you, then you're not doing something right, in my opinion. So you've got to make that hard decision. So leadership skills is holding accountable for decisions that are being made, for actions being made, but really inspiring a shared purpose of what you're doing. So we incorporated that in the document. So these are 2 cases I'm going to present, and we're going to go through them. I got to tell you, avatars. I probably spent more time making these avatars than working on my talk. I'm just kidding. I didn't. But I'll tell you what app I used to do it. All right, here's the first case. So we have by the time I saw this patient, it had been 8 months, so it's a little bit of off, but at 5 months, the first encounter, but bilateral hip pain for 8 months when I saw this patient, and a 15-year-old female cheer athlete. She'd had initial pain during dance when she felt pain in her left anterior superior iliac crest. And then she took a summer intensive class over break over 4 weeks and dancing up to 5 hours a day, 12 hours a week. And then it began to involve her right side. And by the early fall, she had to stop dancing. It hurt so much. She saw her longtime PT, who she had seen for previous injuries over the course of the previous 3 or 4 years, who referred her for an orthopedics evaluation. And the orthopedic surgeon did an x-ray of the LS spine and the pelvis, which were normal. Vitamin D was 22.2, which is normal, but low normal. And she was started on supplementation. And she was so painful that she was placed on crutches, partial weight bearing, still so painful that she became a wheelchair user. And then placed back on crutches, and an MRI was ordered. And she continued to see PT once a week to help alleviate her symptoms. So the x-ray of the pelvis, which is challenging to see, and I don't think we have a pointer. Do we? Here's my pointer. So here you can see that iliac crest. See that separation there on the right side, right? And you can see it on the left side as well. There, okay? So you can see that developmentally, but it was read as normal, right? And then, which is interesting, right? Because she's 15. So menses history is important. Had already started menses. The MRI of the pelvis was done, and this was the reading. And again, it was subtle changes. I'm going to go ahead and blow it up here, but it talked about bilateral fracture of the iliac apophysis with 5 millimeters posterior displacement. And you can see this is the AP view, coronal view, and this is the axial view, but here's where they're pointing to that. Edema, there's the growth plate right there, right side worse than the left, okay? So mild edema. So that was initial reading. So she continued to have pain though. So then I saw this patient 3 months after the MRI. I'm that primary care sports medicine physician. She was still hurting with walking, but she wasn't using crutches. This was her pain, 6 out of 10, pretty high. It had no night pain, but it was also having some achy low back pain only by the end of the school day. Additional review systems, sad, admitted being sad, right? Couldn't participate in the activities she wanted to be in. And she also, going through the ROS, had a skin rash, talked about a skin rash. Family history, non-contributory, past medical history. So this is someone who had been involved in gymnastics earlier. We had some great talks earlier already today, in dance and in cheer, okay? And you can see that she'd already had multiple MRIs, bilateral shin splints, and mom says had all been slow healing. And again, she had to quit gymnastics, but she still enjoyed dancing, and she was in high school cheer as well. So physical exam, her mood was reserved. She was quiet. Looking at her rash, she had a raised circular scaly plaque on the back of her neck. And this was her exam of her low back. So I felt like she had, I keep walking away from the microphone, but you can hear me, right? Yes. Everyone in the back room? Good, okay. She continued to have she had full range of motion in her low back, but I felt like she was stiffer in her lower lumbar sacral spine. She was tender centrally and bilaterally at the L5-S1 level and along her bilateral SI joints. But she had no pain with active lumbar extension, but she did have tenderness palpating along the bilateral anterior iliac crest. And then seated, I was doing all kinds of things, right, to see if it, what attaches, right, to the anterior crest. You know, what attaches to the AIS, trying to see if we had any element of apophysitis, etc. So I did all kinds of stuff, and you can read that, essentially. Later on in your PDF slides that you see, you can read that. So 3 months later, again, here we are. So now she's been done, so it's 8 months after initial pain, and she's frustrated. Her parents frustrated. And so my first thing I said was reassurance. You know, iliac apophysitis can last. It can last, apophysitis can last sometimes a year or more. I'd already kind of prepped her chart. I knew she was coming to me. Orthopedic surgeon had talked to me about her. I'd done some literature review, had found that these can last for a year or more. So I had a case report that I gave to them. And I just said, you know, you can continue to participate in activities as long as your pain allows, because she'd had pain for so long now, right? So that's got to start to permeate someone's mood, which it did. As long as, you know, this will eventually fuse, continue the bone stimulator, and you know, what other things you like at school? Are there other things that define you that you enjoy doing? Are there any participating activities that you can do that aren't quite so active, right? So that you don't have pain. And then due to her history of long bouts of musculoskeletal pain without identifiable cause and prolonged PT, I ordered labs to evaluate her bone metabolism, also rule out an inflammatory rheumatological cause. And I thought, okay, skin rash, most likely eczema. But in the light of what I was going to measure, let's go with this, right? So here are her labs. So this is was a fairly new. I have to say this is an older case, and I had just joined UCSF. You can tell this case still haunts me. But I just joined UCSF, and so it's a new EMR system for me. But this is how the reports come in, and they come in as abnormal, abnormal, abnormal. Okay. So I went and clicked on the abnormals, and I clicked on these other results too. And this one, final result, abnormal one, I couldn't find, I'm trying to remember this. And I remember clicking on it, and I couldn't, you know, it was not abnormal, clicked on it, didn't actually see the final form, but saw that it was, you know, didn't say abnormal. So I thought, oh, here we are. But all these things, you know, I looked at it, but from one point you see the abnormal ones. And I definitely focused on the abnormal ones, which were just out of the normal range, but not really abnormal. So then the interval history over the next 8 months, she didn't feel like non-steroidals were effective. She wanted to continue with weekly PT, continue with the bone stimulator. I referred her to cognitive behavioral therapy for chronic pain because, you know, no 16-year-old should have the level of pain and be so impacted. And I wanted her to help her with this. I did a follow-up of her MRI of her pelvis because I wanted to see why she was still having pain. And everything looked like it was improving, which that was positive. So I gave her that positive feedback. Did an MRI of her LS spine because she continued to have some low back pain. It was normal. Looked at it, it was normal. And I reviewed again her previous MRI imaging studies again, okay? And I reread it all, and it was like, you know, I'm gonna read this too. Left ankle MRI that was done 2 years prior, minimal joint effusion, minimal synovial fusion, middle synovial thickening, otherwise non-specific findings normal. And all her other imaging study was like some bone edema here or there, whatever, but you know, normal. There was a stress fracture that she'd had. And I thought, do I need to repeat blood work? Let me go back to the blood work and see. So again, we go back to this, right? Here's the HLA-B27. Here are the abnormal labs. And I clicked on it again, and I frankly don't know how I don't know how I missed it, but this time when I clicked on it, this report came up. And it wasn't with it before. So B27 positive. Those of you in the room maybe remember this case, because I have a tendency to beat myself up about things. So there it was. So it's been 1.5 years since the onset of her hip pain, maybe a little bit shorter than that. So one of the things I want to point out is leading with care and holding accountable. So I really held myself accountable for this because I ordered the labs. I should have seen it. So to us, I think it's really hard to, we're counseled about admitting our mistake. At that point, I felt like I developed a pretty good relationship with that patient, although, and I had to just say, I missed it. I missed this. I'm taking full responsibility for it. But now we have a diagnosis. Let's go, right? Let's see if we can help you feel better. So we diagnosed her with HLA-B27 positive enthesitis related arthritis. There was no involvement of SI joints, right? So on the LS spine MRI and the x-rays, SI joints never showed any edema. So anti-TNF was not started by a rheumatologist, and she was referred for yearly screening because uveitis is very common with HLA-B27 for those who had those patients. And she was started on naproxen on a regular dose. 3-month follow-up, she hadn't been taking it. She had an upset stomach. So rheum encouraged to add ranitidine to the naproxen. Here's the other thing. The CBT therapist treating her diagnosed her with pain overlay syndrome, and she expressed concern that this weekly PT she'd been getting for the past 5 years could be a cause of dependence for her overall life. And so that was really helpful as well, because when you think about dependence, right, the ability to when we talk about dependence and having a crutch, right? Think about the crutch and her like wanting to go on crutches, wanting to, use a wheelchair, going back and forth from that, which she had continued to kind of do off and on. But we talked about that, and PT was then DC'd a month later with the interaction with the therapist as well and talking to her. 2.5 years later, she was diagnosed with concussion. She was cheering. She slipped. She hit the left side of her head. I saw her for the concussion. We worked together 3 weeks for concussion symptoms resolved, but she would still have a headache. 4 weeks later, during cheer, hit her left side of her head again. And this time she had a much higher symptom load. She had sleep difficulties, many more symptoms involved as well, really started being concerned about her abilities. She's older now. She's thinking about college, right, et cetera. And you guys all know how challenging that can be with the course load. And I started her on low-dose amitriptyline, referred her back to CBT, and involved our neuropsychologist to talk to her as well. And it took almost 2 months before her symptoms resolved well enough for her to return back to activity. So her next room follow-up visit was 1 year from the previous visit, which was not what the room wanted, but it was what, this is another point of view, was this delay because the family and the patient had a hard time with his diagnosis because it's a chronic disease diagnosis. So anyway, end of this first case is, so I've already kind of talked about through the case some of these complex issues. The first thing I would say is not all musculoskeletal pain is an injury, is a bony injury, is a tendon injury. And if you go out and visit 2 tables in the back, they talk about hypophosphatemia, which is a differential diagnosis for pain, fatigue, joint pain. And I will say one of my good friends who's an athletic trainer at Ohio State University, she was diagnosed with it in her 40s. So it can be a delayed diagnosis, adulthood, depending on the type of hypophosphatemia. So go visit those tables, pick up that paperwork. The other complex issues certainly are, as Dr. Pandya talked about, we had a family who also didn't, they weren't incredibly assertive in terms of doing some things, which I think was based on their background and their ethnicity, and that they're Asian. So challenging, like they didn't say what's going on, is there something else? And maybe I would have been like more active looking back at that stuff. I think I was just not sure, navigating an UEMR without having someone help me dictate. I don't know. I tie that back around. So medical clearance return to play decisions can be difficult. I think especially when she came back in with persistent post-concussion symptoms, that relates back to her experience of pain And that certainly is challenging when you're helping someone and encouraging them and reassuring them of going back to activity. And certainly the mom was part of the dependency issue as well. But how could she not be, right? I mean, this is her child. And then our disciplinary healthcare team was awesome in terms of, the PT, really understanding, okay, I have a role in this. Let's back off a little bit. Our cognitive behavioral therapists, the rheumatologists as well. And the one thing I want to point back to as well is this return to play. Oftentimes you'll hear your physicians, some physicians will say it's all or nothing, rest. Well, that's not helpful. It's certainly not helpful for mood. It's not helpful for integration on a social behavioral aspect, being in school. So it's more like do what you can, or let's talk about what you can do. And people sometimes need guidelines. This is what you can do. And even with someone who's coming back after a concussion, which you'll hear about this afternoon, is there's things you can do that's not going to put them at risk. So let them do it. Okay. All right. Case 2. This is a shorter one. Just as fun. 11-and-a-half-year-old AAU basketball player with acute onset of right foot pain. So this is his practice, right? Year-round practices, 3 times a week for 90 minutes. Here's a weekend tournament every 3 weeks. Yes, I take this history because this is so important, especially when you talk about overuse injuries with our youth athletes. A month prior, had just finished playing flag football and is on the swim team. So really great for diversification of sports, but here we are talking about the time period. Past medical history, no prior history, injury of bony injury. Social history, has a 13-year-old brother who plays AAU basketball and is a phenom. Hopes to play in college and had been treated by me in the past for a foot injury. So physical exam, this was a physical exam. Kind of hurt along the first metatarsal, the navicular bone, plantar aspect of the first metatarsal along the sesamoid. So it had diffuse kind of soreness. And so x-ray was negative and an MRI was ordered. So here's the MRI of the right foot. And let's go close up. So in the close up of the MRI, you can see that there's edema in the navicular here, and the navicular here. But there's also edema at the base of the first metatarsal. And on one of these, there's some edema of the sesamoid. But you can see that edema at the base. Wish I were taller. I always want to be taller. There, okay? So I pointed this out to the family. So management, okay, this is by far the youngest person I'd ever had with a navicular stress fracture. Has anyone ever seen anyone any younger? Okay. So the management of the navicular stress fracture, there's data on it, but it's all in adults, pretty much. And it's crutches non-weight bearing for 6 weeks. Okay. And there was as read by the radiologist, there was also a crack that you could see on the MRI. Okay. So I said, let's manage you crutches non-weight bearing in a short leg cast for 4 weeks. And I started talking to people because I'd never seen it. So I talked to Dr. Pandya as our pediatric orthopedic surgeon. I talked to colleagues of mine in the MBA. Now, granted, MBA, but certainly, basketball, or had you ever seen anyone younger? Because, I wanted to get everyone's input on it. So people that I knew, and no one had ever really seen it, but they were like, this kid's a kid, and we all know that the navicular is the keystone of an arch, and if that doesn't heal well, they're destined for chronic pain for the rest of their life. So let's just manage this conservatively, right? And they're not an NBA player. Right? Okay. So 2 weeks later, returned to the family because the cast was loose. Cast really didn't seem loose, but it was loose to the family, loose to the kid. And after removal, they said, well, poke on it. No pain on palpation. 2 weeks later, over the midfoot, follow-up x-ray was negative. I wasn't going to get a follow-up x-ray, but they asked for it. And I decided to change him to a walking boot with only touch-toe weight bearing for 2 weeks. And we started PT 3 days later for range of motion, core strength, no loading. And again, as you guys know, someone in a cast is going to atrophy like crazy. If you put him in a walking boot, you can at least take him out of the boot. You can start non-loading type of exercises to try to at least keep bulk, right? And this was really, really important to this kid and this family. So this is the compromise that we started doing, right? Totally okay with it. Communication is really important. At 4 weeks, no pain on exam. This was our plan, okay? Wean crutches, plan on another 4 weeks in a walking boot at all times. 8 weeks, all weight bearing. Advanced PT to partial weight bearing exercises, no flip turns because swim team had started. Stationary dribbling, set shots okay in the boot. CT scan was ordered for about 6 weeks, okay? Rather than the MRI desired by the family. And the family had said, we don't want radiation. And I said, an MRI is going to show edema for a while. And if you really want to see healing and I want to make sure I'm comfortable that it's going to be healing, let's get the CT scan, but it's certainly up to you. Now we have this wonderful new device that you can read about in the back that was just installed at Oakland's campus, and it's the multi-tom racks. I will tell you that when I started medicine, we did tomography, and then we stopped doing it. But this may be an option. I'm not familiar with it that much, but lower radiation than a CT scan, and is it good for seeing like those types of dense bones like navicular bone? I'm anxious to learn more about it. However, this is all plugged to go visit our sponsors because without them, we couldn't hold this conference. Did I do a good job? Okay. All right. She didn't ask me to do it. I just did it because it's important. Okay, so family sought an outside MD opinion 1 week later. So they did not tell me they were seeking this opinion. I can just read it because it comes into sometimes our notes, but a little bit later. I didn't have any idea till later. And it's interesting because that injury was documented as happening 2 months prior, and it really happened 6 weeks prior, right? So all of a sudden they're accelerating this diagnosis because they're really engaged and want to have him come back earlier. So I'm reading this, and this outside MD is what I am, a primary care sports medicine physician, younger than me. I say younger, less experienced than I am. But I'm like, okay, well, it's good. So this person agreed with our plan, which was great. CT scan was done. I obviously didn't know about this. Here's the update. So essentially, you can see that even without this weight bearing, there's already some, right, diffuse osteopenia happening here. This is the navicular here. But then what's read by the radiologist is having some increased sclerosis, okay, of the right navicular. So that's great. I said to the family, that doesn't mean it's healed, it means it's healing. So we're comfortable with what we're doing progression-wise. All right, so we're gonna fly through this. So MD called to review the CT scan results. I called them. Family expressed desire to let him out of the boot for rehab so that in spring break, a couple weeks, he could enjoy the water park. The family sent the CT scan to the outside MD. Again, still wasn't telling me that had done it. I actually probably didn't even know about this till a little bit later because it takes a while for the notes to come in from the outside. PT visit was 1 week after the CT scan, 7 weeks after the diagnosis. PT stressed as well, no out of boot home exercises until cleared by me, and had a strong discussion with them regarding compliance and healing. The outside MD was emailed and asked for orthotics and a custom boot to use at the water park. They didn't ask me that. And they said that if we don't agree with Dr. Chang's at the next visit, we're going to follow up with you. Now, it's telling to me that that email never got replied to. So follow-up MD visit at 7.5 weeks. So these are all the things that this young man is doing. I mean, he's good, right? This is what this AAU team is doing, and he's 11 and a half, all right? He was doing this because he was told by his family that more is better. And I would just say, father, more is better. Mom was trying to hold back, but dad was saying this. We did order orthotics, and I said, listen, go to the water park, but don't do certain things at the water park, but when you're in the water, wear a lace-up ankle brace just for support because he wasn't quite what he needed to be. Here's the rest of the story. PT visit, 9.5 weeks. He went in a lazy river and hot tub. He didn't do water slides. He started doing one-leg jump shots. At 9.5 weeks, he wore the over-the-counter insole in a water shoe. That's what he was doing when he was there at the park. That's what I found out. His calf atrophy was improved. He was still weak on eversion, so he still had rehab ways to go. I let the DPM, I talked to the podiatrist about how to transition from the boot into orthotics, only at home to start. I advised him to keep wearing the boot. He could transition out, but I said, it's gonna make you feel a lot better if you're wearing the walking boot, because then people can see that you're injured. And they don't have to say, hey, why aren't you playing? You know, it's like a concussion, right? People don't know. So it was like, wear the boot. You're not gonna need to wear the boot by then, but just wear it so people know why you're not playing in this 3-on-3 national championships. So he got out of the boot faster, and he told me it was because my dad said I could, and how I felt. And my dad said that he trusted me, and if I didn't have pain, I could go out of my boot. This guy's 11.5. And multiple other MDs have said the family checked around with multiple other MDs and said, she's treating you too conservatively. Okay, so here's the MD visit at 11.5 weeks. He's still not strong, but he's got knee valgus, decreased balance. We all know, right, that ACL, lower extremity injuries increased. And then started Alter G, mini jumps on the tramp. And as far as I know, he's done fine after this. Okay, so first of all, the pediatric foot's a lot different. I didn't mention that there were some other areas, like this second metatarsal head was edematous bilaterally, but that's developmental osteochondrosis. It's kind of a developmental change that can happen that we can see. Oftentimes we see it in the medial femoral condyle as well, where we get an MRI and it looks funny and we're like, what? And it's really just a developmental. So know that the pediatric musculoskeletal system is very different. I think it's really important that youth athletes, even though they're not college athletes, they're not professional players, their mindset is that that's what they want to achieve. They have a role model in their brother. They are certainly encouraged to be excellent by their social support, and you can't, they're to bind too, right? So you can't blame them. You really don't want to blame anyone, right? I will say that I had some implicit bias because, Dad taught me a lot about myself as well, but he was a high-ranking CEO, right? Mentality is such push, push, push. You don't get anywhere until you push. And I'm going to find out the answer, and you don't know the answer because you've never seen it before, and therefore I'll find out the answer. And you have to be humble about it a little bit, like not be offended. Like that even came out when I said the other person they saw was younger than me, right? But it was like, that even came out in my talk, right? You shouldn't look at it from that perspective. It's just like, okay, another opinion. That's important, right? They can get opinions. And what I would suggest to you is if someone asks you, offer it first. Say, hey, if you're not comfortable, and I did that. If you're not comfortable, because at one point it was like, well, you're not a pediatric orthopedic surgeon. I'm like, you're absolutely right, I'm not. I have talked to the pediatric orthopedic surgeons I know, but if you'd like another opinion, here's some names. And I would say, have that ready, because you don't want them going to someone that you know is going to be bad, that you know is going to give them an opinion that is not going to be good. You like that black and white comparison? But have names of people that you trust, that you know are thoughtful, have the same values that you share, okay? That are not going to jump to surgery because they need money. That was, you know what I mean. And then in terms of the team, in terms of the, again, in interdisciplinary healthcare teams, it was so important to me that my PTs supported, right? That they supported the message. It's the same thing that we talked about in terms of what do they hear versus what do they hear at their follow-up visit, and to have that continuous support. And it was important to me that my colleagues, that we all were supported together. And as I finish this talk, I will say there's a lot of other complex situations. And as a parent, these are my kids. My daughter played, that's her in her professional uniform for France, but she played at Yale. Go Bulldogs, beat Auburn, by the way. But she was a walk-on at Yale on the soccer team, and I watched her tear her ACL on video because I was watching her game remotely. Her athletic trainer was by her side, did a knee exam, first on the normal knee, uninjured knee, and then on her injured knee. I saw the translation on her injured knee. I talked to the athletic trainer, and she said, I feel like she tore ACL. I talked to the team doctor, who said, oh no, she dislocated her patella. And I said, well, I saw the athletic trainer's exam, and I talked to the athletic trainer, and the physician said, oh, all girls this age are loose. And I'm like, bullshit. I didn't say that. I said in my little brain, it's a little brain, my little mind up here, speaking voice. But I said, oh, okay. But so another complex situation where you're emotionally invested in your child. So what do I do, right? I'm a colleague, and that was a challenging situation. My son had 6 concussions by the time he was a first year in high school. And at one point he said to me, Mom, when I said to him, you got to stop playing soccer. You got to stop snowboarding. You have to, and he went, I don't agree with what you're saying, and I want to see a real concussion doctor. So, that's him, still playing soccer. And I will say that we don't think about it. We enter into these complex decision-making processes all the time. And so just know to develop a team, have the right people around you, support structure, be confident, but also know your limitations and when you need help. And I think I'm done with my talk. I think I went over.
You nailed it perfectly.
Okay, all right.
On the nose.
I showed torn ACL. Did you get an apology?
Excuse me?
Did you get an apology when the...
I showed the torn ACL. What did they say?
No.
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 Time for a couple questions.
So I just have a quick I'd love some resources, because I practice in an area where all my patients are playing multiple sports. They're on the club level. I'm really worried about overuse injuries, the anxiety, all the different components that go along with these kids who are just being pushed and pushed and pushed, and they love it. And so they're being not just pushed by their parents, but socially, it's like what they do, my kids included. And so I, as a pediatrician, I go in there and I talk about these, we need to think about them not doing a single sport. We need to think about their mental health and all of this. And they listen to me, but if I had, and even one of my own kids' coaches who wants them to just single sport, and I'm saying to him, hey, I don't want my own kid to single sport. Do you have a good list of resources that we could potentially provide for people as the pediatrician who's just trying to help these kids?
So Lita, you can answer some of these questions too. I would say that there's like 2 good points. That if we know that there's an increased risk of injuries, let me just change that too. Kids don't think about injury. I was just gonna talk about NERU's data about, that if you participate in organized sports more hours than your age, you're at much increased risk of injury. And what I tried to tell this basketball player was, hey, his parents, his father, was, this is a short time frame of resting, because if you keep going and if you push this, you could be out a year. And I kept on saying NBA players, if you tear your ACL, you're out a year, like kind of that short term, long term. I will tell you that I am the first thing that I would suggest is that, and you probably do this, is I talk to my patients without their coaches in the room. Clear at Cal, if a coach came with an athlete, I would say, you need to wait in the waiting room, please. Please wait in the waiting room. Our policy is, please wait in the waiting room. I want to talk to the athlete first. And I do that with the pediatric patients too. Maybe not the first visit, but on a follow-up visit, I may say, hey, let's just start off with just talking to the patient. And then I just kind of say, how are things going? You know, just to make sure they don't feel like they're pushed, right? But you're right, sometimes they don't know. And what's amazing to me is that I've had patients, and we all have had patients, I think, that get injured. So classic, Caitlin, are you here still? So classic is a gymnast who they're gonna get hurt. And this happened to my daughter when she was doing gymnastics. And the coach said she could still come in even though she's hurt. She could still come in and do, you know, we'll keep her busy. Like, she's freaking 8 years old. Sit-ups and, you know, and I'm like, so I finally, and she wasn't getting better because she kept doing stuff because she was in the gym. And I finally said, cease and desist, you're gonna be out of the gym, you gotta let this heal, you're out for 6 weeks. She came back at her fall visit, she said, she initially was crying, I can't leave my friends, whatever. She was 13. She came back, she said, I have found a love of drawing, and I can finally go to birthday parties. And she stopped gymnastics. So sometimes their identity is all wrapped up in that, which is what I was trying to do with this gal with the dance, you know, cheer, was like do other things to develop yourself. And I don't have an easy answer for you, only because my kids said, I want to do soccer. And so the avenue is like, they were better than a rec team, right? So they started playing club where you get better instruction. But because I was so diversify, I had them doing other sports. I was overusing my kids. I mean, they were definitely overusing themselves, but I was trying to keep a balance on it too. But I was also making them ride their bike to practices in school because I didn't want to drive them. I mean, it's crazy, right? And I have this other lecture I do about overuse, so I was adding up the hours of all their activity. They were totally doing more. But the other good point is recreationally, if they're more in a high school or a middle school or recreation sport or a pickup game, they're more likely that they're going to pull themselves out because there's no pressure from an adult saying you got to do it.
The coach.
Yeah, it comes down to the coach.
Yeah. And so how do I?
So there's two strategies to negotiate these things. Is what I've learned, through my practice. One is if you want to go the intellectual route, there's a lot of resources from organizations. But if you're trying to fight, say popular opinion or then you can go through the media route, right? We do have more, professional agencies kind of speaking up about these issues, and more research is coming out, from these pro athletes about, diversification and not specializing in things like that. There was an article, ESPN, I think it's called, these kids are like ticking time bombs, right? Right, so.
No, it's true. I'm sitting here shaking my head because now I'm a CMO for the National Women's Soccer League, and we just signed another 16-year-old for the San Diego Wave. And you're like, oh. They're like, develop policies, Dr. Chang, so that we don't overuse these kids. And I'm like, oh. So, yeah, I think the other thing we talk about is performance. So what we're really trying to do is develop research on overloading. So if you fatigue, you overload, you do too much on a developing skeletal system, it goes back to what Leon was talking about. I mean, weight training is great because it develops strength and stuff like that too. But the fact is that if we can focus on doing too much, fatigue, decreased performance, and increasing injury, that's where I think we can get someplace. Is the performance, prevention, and performance. And so our focus has to do that. And can we do a better public service message? Yes, but will people listen? I mean, coaching, like Dr. Pena said, this is a full-time job now. And some coaches, what we're trying to say is, yes, develop your coaches, but develop them to not just be soccer coaches, but then to coach swimming, and then to be a good coach. Because if you're a good coach, like you don't have to know how to swim to be a good swim coach, right? So develop these academies where there's multi-sports so that your kids are doing a different sport every season. And then you build in this rest. But you still can pay your coaches year round. Because this is what's happening. Coaches are becoming youth coaches and they're year round, so they need to make a salary year round. There's no easy solution, I'm so sorry. But thank you for being, and last thing, God, I could talk forever on this. The last thing is the voice, your voice, right? So I just talked to Alan and Asha about this. They didn't have a voice their first year, or maybe even their second year. So if a coach said, you need to do this, and they had pain, they were, like, do they have a voice to say, I kind of hurt today? Or no, I did too much yesterday. But now as seniors, they have more of a voice. But think about these kids. Are they going to speak up to an adult? Right? And because they don't want to seem weak. And so what we have to do is, as well as educate our children to have that voice and to be able to speak, to adults about how they feel. But it's important for coaching education for the coaches to also give this education to say, you've got to listen to your players and parents. And parents are fearful of talking to coaches because they don't want to decrease their kids' playing time. Because that will impact their ability to get a scholarship or get into, get tagged or get into, whatever. And it's unfortunately this cycle. And
Is that actually a question related to that? I'm also a primary pediatrician about here, which is
oh,
so yeah. So I'm also a primary pediatrician. But, the whole thing, same stuff. And I have a kid who's diversified, so now he's doing 30 hours because he's doing both baseball and okay, God, that didn't work. So is there a way to? I mean, it's a huge thing. You might have some impact, which is. I point out, a professional athlete does not have 2 full-day tournaments with 6 volleyball matches in Chicago for the weekend. Like, is there a way to somehow change the youth? It's a huge project, but I think that's going to help the overuse, because the problem is these kids literally are in these tournaments where they play, 8 hours, 2-3 days in a row, and I mean, that's got to be part of the problem, right? So how do we address that?
So it's what Dr. DeBoer said was about using these professional leagues, because our players union, for example, NWSL, they're like, they scream if they've got Wednesday, Saturday. Like, they don't like to play 2 games in a week, right? They feel like it's too much load for them. But we've got Cal, we have events happening. So Cal plays their games Friday, Sunday for soccer, I'll just use as an example. We've got tournaments where they're playing 4 games in a weekend. So that's when we can start to stress is like, this is not happening at the professional level, where they're training and they're ready and they have recovery and they wear Normatec boots and they've got shock therapists. But yet we're asking our youth athletes to do this? So I think that if we can take that trickle down theory, and the NFL is doing a great job with messaging, they're doing a better job with messaging in terms of, it's because of restricting practices and contact, and it's coming down to the youth level. They have a great study they've just done. I was just at the Research and Innovations Committee meeting, but where they showed that in preseason, you have to ramp up slowly to prevent injury, not start off right away doing these practices that are leading to injury. And I would suggest, for those of you that are pediatricians, athletic trainers, PTs, whatever, that if you have kids that do love sports and they like to play everything, right, is that you identify a primary sport and then a secondary sport. And if they're the same season, that you compromise and say, this secondary sport then, you can miss games and you can miss practices. Because that's not your primary sport. And if that means you sit on the bench and you don't play as much in your secondary sport, that's okay, because you missed the practice. And that means you're not committed. And if you're a good athlete, decent athlete, I mean, again, if coach is punished because of that, then maybe you don't want to play for that coach. So try to at least have them delineate priorities. But the first priority always is school. Always.